Hello, friends. Good morning. So, so this is a topic which I wanted to talk about. So, this may be a very emotional topic to some of the intensivists like us. So, obviously, this is something which is the sacrosanct to me when I talk about ICU. So, as a representative leader of intensive care community in India, so I believe that we have a lot of work to do with regards to how we run the ICUs. So, friends, I've come back to India since 16 years back. Before that, I was in Australia for 8 years. And after my medicine post-graduation, I worked in St. John's ICU. So, way back in 2001, uh, 98 to 2003, I worked in St. John's. Even then, in St. John's, we ran it as a pretty much intensivist-led ICU or a closed ICU, and my mentor Sriram Sampath did work as a closed unit, friends. So, which means from 2000 to 1998, I'm talking 1998 to currently 2025, nearly 25 years in ICU. What I think we have failed to reconcile in India is that all ICUs, if you are talking about running as a center of excellence, should be intensivist-led ICU. Although I would want to use this closed ICU little bit sparingly, but it has to be intensivist-led ICU. If someone is not running it as an intensivist-led ICU, then they are faltering in the quality that they are delivering. And the context setting is the big nationwide study that came in South Korea in 2024, which I'm going to talk about it, has re-emphasized how important it is to run an intensivist-led ICU. And in this study, they gave incentive to an intensivist to run it as a closed ICU and showed a 22% reduction in ICU mortality, friends. So this is where we are at. And 25 years since I have journeyed in intensive care, it pains me to see that many hospitals in India, not necessarily maybe intensivist led. And the context setting is recently one of the chairmen of a chain of hospitals says he doesn't believe in closed ICU model. So this really pains us. And for the future generation, it is imperative that you need to take on the ombudsman or ombudsmanship of running an intensivist led ICU or a closed ICU model. And this is where we can transform the healthcare and intensive care in India, friends. So we'll talk about what is the evidence for running this as a closed ICU. So this was the article that I was mentioning, which was published in 2023, trained intensivist coverage and survival outcomes in critical care, nationwide cohort study in South Korea. So the whole nation, they did a study in ICUs. So it's a beautiful article. So I urge every intensivist to cite this article to the healthcare leaders and say how intensivist makes a difference to the outcome. If it is intensivist-led ICU, it has to be intensive care decision making that needs to happen in a closed model that has shown phenomenal outcome difference. So these are some of the studies I'll take you through. There are these four landmark studies which have clearly shown that intensivist-led ICU running it as a closed model has significantly reduced the mortality. I'll take you through details of certain landmark studies. You don't need a better meta-analysis like this of 90 studies with 44,042 patients where they compared closed ICU versus open ICU. And the evidence is out there, written on the wall very clearly, loud and clear, that it closed ICU was superior in influencing good outcomes with reducing mortality and reducing ICU length of stay. So, this is the biggest meta-analysis. I'll talk about other meta-analysis that I came from Canadian group as well, which is very clearly shown. You don't need any more evidence to say it has to be an intensivist-led closed ICU model at this point of time. So the first study came from this particular publication from US, potential reduction in mortality using an intensivist model. So this was from a Leapfrogs group hospital. They are the ones who really did good work in trying to ascertain how intensivist-led ICU influences good outcomes. So they took 9 studies where they showed intensivist-led ICU led to reduction in mortality by 15 to 60%. And full implementation of this led to 53,850 lives saved per year. So this was in way back in 2000. They showed 60% reduction. And the South Korean study, which came just 1 year back, showed 22% reduction. So even now, we may not have progressed well in India to adopt this model of closed ICU or intensivist led. I mean, so many intensivists coming out now. It is about time that we champion the cause of closed ICU and intensivist led ICU care. So, conclusion of this particular study was feasibility of nationwide implementation of intensivist led ICU is uncertain, is what they had concluded, but they clearly showed there was a significant reduction in mortality. So this was another study which came in JAMA 2002, Physician Staffing Patterns and Clinical Outcomes in Critically Ill Patients, a systematic review. Again, 18 studies. So throughout this narrative, when I say high intensity ICU, we call it as high intensity ICU when it is a closed ICU model. And they compared with open ICU is called low intensity ICU. They compared with open ICU. This was a systematic review of 18 studies. Look at the hospital mortality was lower in 16 out of 17 studies showed lowered hospital mortality. Look at the confidence interval, statistically significant. And ICU mortality, 14 out of 15 studies showed reduction in ICU mortality and significant confidence interval. And hospital length of stay was shown to be reduced in 10 out of 13 studies. ICU length of stay was shown to be reduced in 14. So it means there's a whole heaps of evidence there telling you that the closed ICU saves lives and reduces the hospital length of stay, reduces ICU length of stay. Friends. The conclusions they made was, when I say high intensity ICU, it's a closed ICU, which is run by intensivist led ICU, reduces ICU and hospital mortality and length of stay. So this came in JAMA in 2002. So this was another study which was a surgical. See, there is this fashion now. I think as a spokesperson of intensive care, we cannot afford to have surgical ICU run by surgical intensivists, liver ICU run by liver surgeons, and MICU run by physicians, neuro ICU run by, gone are the days. It's about time the hospital directors, chairmen, leaders take a cognizance. There's no evidence to suggest that these models influence the outcome, friends. So this is done in surgical patients, systematic review in surgical patients. This is a retrospective study in Thailand, 2,269 in surgical. It was an open versus closed ICU where it was led by an intensivist. They showed ICU mortality was significantly less in surgical intensive care where it was led by an intensivist, 23.4% as opposed to 27%. And the effect in reduction was more pronounced as the patient stayed longer in closed ICU. The mortality reduction got better and better, and as opposed to someone who stayed in an open ICU. So with increasing time, the closed ICU's performance got better and better. That's what it showed. Risk of death reduced and ICU length of stay also significantly less in closed ICU. So the conclusions they made in this Thailand study was closed ICU, reduced ICU mortality, reduced ICU length of stay, and the effect got pronounced. Closed ICU functions better and better. The patient stays longer. It's a become fashion now in surgical ICU or neurosurgery or anyone for that matter. If it is manned by non-intensivists, they keep them for 2-3 days. Things are not getting better. They move the patient to ICU. Why? Because they know things are going to get better, because that's what science is telling you. The longer they stay in a non-intensivist led ICU, worse is the outcome was shown in this particular study. Now, this is another study, which is the landmark meta-analysis which came by Wilcox et al. In 2013. Do intensivist staffing patterns influence hospital mortality following ICU admissions? They took 52 studies. You don't need a better evidence than this. Look at this. They looked at intensivist-led ICU and non-intensivist. Mortality was lower. And you look at the confidence, all the ones that are marked in the red boxes are statistically significant. ICU length of stay, hospital length of stay was significantly lower in intensivist-led ICU. High intensity daytime staffing, which means it's a closed ICU. In SICU and MICU, the mortality rates were significantly lesser, as you see, as compared to the non-intensivist-led group. So the conclusions they made was high intensity daytime. When I say high intensity daytime, it is a closed ICU during the time, which was intensivist-led, reduced ICU mortality and hospital mortality. You don't need better. 52 studies showed good mortality reduction. So now coming back to this Korean study, which came in 2020. So we have enough 52 studies, 94 studies, meta-analysis, landmark studies showing you that closed model with an intensivist-led ICU significantly reduces mortality, has been shown, written on the wall, written on the stone. So you don't need better evidence. And now, 2023, there is this study that comes from Korea, which is a nationwide study, retrospective cohort study. And so this was one study in Singapore where they said in patients with ECMO, intensivist-led ICU improves outcomes. So even ECMOs or any other interventions, it has to be intensivist-led, which has shown improved outcome. So there are questions with regards to the training of the staff that should be there and the quality and the processes that are in place, which obviously act as an adjunct to improve the outcomes. And there are questions as to what should be the ratio of intensivists to the patients to influence such outcomes are some of the questions. So in this particular Korean study, it was a nationwide registry data. It was done from Jan 2016 to 31st Jan 2019. Look at the number of patients, friends. This is a nationwide, which is 1 million patients they have taken, 11 lakhs 47,493 over 3 years, nationwide ICU patients they took. And they had 4 lakhs 84,000 patients treated by intensivist-led ICU. Here they gave, the South Koreans passed a law to give incentive to the intensivist to run it as a closed ICU beds. And they compared with the group which ran as a non-closed unit, 6,63,489. Look at the hospital mortality, 22% lower, where intensivist was paid an incentive by a special law that was passed in the South Korea, incentivizing them to run it as a closed unit, and they saw this difference of 22% lower mortality. You don't need better evidence in the recent way how we as an intensivist, as part of ISCCM, we have to take the ombudsmanship of driving into intensivist-led ICU. This is what, as a representative leader, I would urge my team to look at it as a proposition and work towards it, friends. And they even followed the patients for 1 year. 1 year mortality was 15% lower. You don't need better data than this. And they've substratified the patients. And they found intensivist was able to lower the mortality irrespective of age, irrespective of the Charlson's comorbidity index. Intensivist was able to reduce the mortality, irrespective of whether the patient was a surgical or non-surgical case, irrespective of the invasive procedures that had to be done in ICU. Or across all the strata of patients, intensivist-led ICU led to reduction in mortality in all subgroups of patients. Now one may say, oh, in ECMO, maybe non-intensivist or CTVS or someone else may be better. In CRRT, maybe nephrology is better. Neurosurgery, someone else may be better. No, the answer is no. Look at this subgroup analysis they did. They looked at age, then they looked at Charlson's comorbidity index, then they looked at surgical patients. When they say surgery, it includes all surgery, liver, neurosurgery, cardiac surgery, abdominal surgery, all surgeries which are managed by intensivists showed reduction in mortality. There's no business for liver surgeons to say they need a liver ICU, neurosurgeons to say they need a neurosurgical ICU, or a trauma surgeon saying they need a trauma ICU. This is an obsolete and superfluous, because where we trained in Australia, which is one of the best ICUs, there's nothing like this liver ICU, there's nothing like neurosurgical ICU, there's nothing like trauma ICU. All ICUs came under a team of intensivists to run it. This is how we need to shape the intensive care in India, friends. If at all, we need to subscribe to evidence. If you don't want to subscribe to evidence, you follow whatever that needs to be. And even in mechanical ventilation or no mechanical ventilation, intensivist-led ICU showed reduction in mortality, whether patient receiving dialysis or no dialysis. ECMO, intensivist led to reduced mortality. No ECMO, intensivist run ICU led to reduced mortality. So this is where the evidence is. So we have to stick to the evidence. We have to influence the outcome to our patients. We have to stick to science. There is no witchcraft that can determine which patients do well. It has to be this. The science from 25 years tells us very clearly 90 studies, there are 90 trials at this point of time, which has evaluated. And this nationwide study in South Korea very clearly points out that intensivist-led ICU is what reduces mortality by 22%. Tell me one intervention in ICU now which shows 22% reduction in death rate, friends. And the conclusions they made in this particular Korean study was intensivist-led ICU with closed ICU design, reduced hospital mortality and reduced up to 1 year mortality. What more you need? You not need. And it shames us that if a owner of the hospital's chairman or the healthcare leader say they don't believe in uh, closed ICU, it means they are deviating from the quality. They are deviating from the science of intensive care. And possibly it is a malpractice now to run the ICUs in the open format to a large extent because you wouldn't be giving optimal care. And this was irrespective of all this age, Charlson comorbidities, invasive. So now the question is, why we believe intensivists in ICU improve the outcome? Why do we believe intensivists change the outcome? So benefits are shown, intensivist presence reduces morbidity and mortality. Intensivist is the one who coordinates with other teams, gains concurrence and consensus in executing the decisions. And there is a continuum of care. Intensivist is stationed in ICU. So a specialist who comes into ICU, maybe for 30 seconds or 5 minutes, 10 minutes, cannot determine the plan for next 24 hours. It cannot happen that way because the trends in a critically ill patients are very fluidic and they keep changing hour to hour. And someone stationed there monitoring them, their decision has to be valued. So the continuum of care is what matters. And intensivist is always present on the floor, and the close attendance of intensivist has a bearing on the outcome. Most importantly, absolute conviction to me is the communication with the family to a point of establishing good rapport is well done by the trained intensivists because they are constantly communicating and they are trained in good communication skills. So rapport with the patient and family satisfaction has found to be enormously better with intensivists. This is all the science telling you. It is not Pradeep Rangappa telling you out of his belief system. It is the science telling you there is a continuum of care, there is a close attendance, and better rapport and communication happens with the on-site intensivist present all the time. And it is also shown there is reduced cost to the patient by minimizing inappropriate admission, and constant continuum of care prevents complications, and there is prompt discharge of the patients that happen from ICU. And even triad by intensivists has found to be a lot more superior because there's always the decisions are based out of risk benefit balance that are constantly evaluated by the intensivists. And obviously, intensivists would continue certain life support measures only when there is a reversibility quotient to the underlying disease or there is benefit from offering advanced life support measures. And intensivist is the best sort of a trained or best sort of a personnel who can determine when to stop life-sustaining therapy when the measures put in place are futile. No other specialist can make this decision better than intensivist who can determine the non-continuation of life-sustaining measures. And admission discharges are better planned by intensivists. And we are the one who adhere to the core principles of evidence-based, and we are driven by the guidelines, and we understand the importance of robust processes that need to be put in place to influence the outcome. And intensivists understand the importance of physiological age and physiological age and not the chronological age. So these are some of the key skill sets of an intensivist which can influence a good outcome. And intensivists are trained in the leadership qualities because we exercise different types of leadership, like autocratic in the type of crisis situation, or democratic, which is consensus, transactional, and most often it is transformational. And intensivists are best suited. They work as a team. They're constantly working with the teams, and they empower the team members to participate in decision making towards the goals that they have set, which leads to higher performance. And is shown, intensivist presence has shown reduction of burnout syndrome in their team as well. So, and finally, this was a sort of a consensus statement that came from the US, which puts out a best practice sort of a recommendation for intensive care, which says ICUs with an exclusive critical care service and operating in the closed format may have improved outcomes. So this is a consensus recommendation from the group of intensivists in US which has put out this sort of a quality statement that it has to be intensivist-led ICU. So as you see, friends, I think for too many people working on a patient can definitely not make a good sort of a dish. So it has to be led by one person. Obviously, you take inputs. I'm not telling when you take those, I see we don't talk to others. We take valuable inputs, but the decision of certain therapeutic modalities, diagnostic modalities, interventional modalities have to be determined by intensivists, of course, in consensus, of course, in concurrence with the other teams. But it cannot be other teams coming to ICU and making a decision for the patient without having consensus with an intensivist is the take-home message, friends. So as a representative leader of intensive care, I urge all the future intensive care trainees to work towards ombudsmanship of running it as an intensivist-led ICU in a preferably closed ICU format to significantly influence favorable outcome to our critically unwell patients. So thank you, friends. Thank you, one and all. And you can show this video to the health leaders if you are going for a job, because I was told by one of known personnel who went to a job and the hospital owner said he doesn't believe in a closed ICU, which is very, very embarrassing for a group of intensivists like us. Maybe this video has to be shown to them if they are interested in reducing the mortality, improving the outcome of their critically unwell patients in all spectrum of specialties. It has to be intensivist-led ICU in a closed format is the way to go, friends. So request you all to submit your valuable work to Journal of Acute Care. So you can visit my website to read to this lecture. Thank you, friends. Thank you, one and all.